We are live now, doctor.
A warm welcome and good evening to everybody. Another very interesting journal club, which is in collaboration with the Young Ophthalmologist Society of India, with the Tamil Nadu Ophthalmic Association and TJOSR. So today's topic is Cornea Unleashed, No Pressure Era. But before we start the journal club, so this is one of the journal club series hosted by Team YOSI, and today it's in collaboration with TNOA. Publish or Perish, a call to action, led by a dynamic team by Dr. Devakant Mishra sir and a team of dynamic executives. This was started way back 4 5 years back. The YOSI Journal Club was done catering to young ophthalmologists, fellows, PGs from first year, second year, third year. So it was customized from all these five facets to assess research literature, defining a problem, how to specify the research question, defining the variables, selection of subjects, selection of appropriate research designs, analysis, and the MAARIE format in a particular template. So we had a presenter mentored for a month, along with two moderators, a research expert to decode the statistics, and then a panel discussion which follows. So the MAARIE format, the method, assignment, assessment, results, interpretation, and extrapolation were dealt in detail by a step-by-step approach. And this is the team YOSI JC, myself in charge, along with Dr. Sonal, Dr. Niranjan, and Dr. Anujit, Ayushi, Shreya Jain, and Dr. Ritu. So we started this, and if you guys are watching this, it's an all-inclusive journal club where anybody can be participating in this. You just need to scan this QR code to access all the previous journal club issues as well. And you can also be on the other side. And this is our Google Forms, and you can also shoot a mail to us. We will be able to respond to it and also share your feedback and your suggestions too. So this started in 2021, as I showed, with 4 capsules in various subspecialties. And then in 2022, we had 5 episodes again in subspecialties. But in 2023, you can see we increased it to 7. And we also partnered with the Indian Journal of Ophthalmology with Dr. Vanati ma'am for IJO live wire for biostatistics. And in 2024, we kept moving in the same direction with 6 capsules and all untouched topics like case reports, photo essays, original articles, reference management, avoiding plagiarism. And you can see the topics below: publishing, writing, and beyond, dealing with rejections, and mastering research, along with the various subspecialties which we altered every month between the IJO live wire. And in 2025, we had again another biostatistics, followed by another 11 series or 12 series of subspecialties. Again, Dr. Niranjan was very instrumental in bringing a financial partner, Micro, on the board. So with that, we were able to bring in a lot of keynotes along with our industry partners. And this journal club, it takes immense pleasure that we are starting a new collaboration with TNOA. Thank you, Sujata ma'am. We would like to warmly welcome you, ma'am, for being here along with the team YOSI for this first of its journal club, where we are collaborating with the state journal. And we warmly welcome you, ma'am. A few words from you before we start today's proceedings, ma'am.
Thank you, Prasanna. As usual, it's been a very impressive past what you have shown us. It's very, very impressive. And this is the need of the hour. Actually, a lot of people have lots of ideas, but how actually to go and publish is very difficult. And think coming from YOSI, it definitely will attract a lot of traction. And one of the most important things that I liked was that how to publish. That is the most important thing, how to write a journal. All these small, small things will really have a lot of important this thing. And I'm really glad that you were able to include us in your venture. And you, as usual, you have on top of the top of everything, whatever you guys do are amazing. And we have a lot to learn from you. With these few words, congratulate all of you, particularly the Journal Club YOSI, for bringing forth this type of webinars, and all the very best. Looking forward to it. And since it's a cornea-based webinar, I'm going to attend it fully.
Thank you, ma'am. So the moment, yeah. So this journal club again, Cornea Unleashed, no pressure is the topic. We have the article for discussion followed by a keynote speaker, and we are going to have statistical critic. And we have also started with a resident corner very recently, where the residents can put their queries in the chat box. We also have Sujata ma'am with us, who's again an excellent cornea specialist. I don't need to introduce any further. Ma'am is currently the president of TNOA, and handing it over back to Shreya, who has orchestrated the whole skeleton of this journal club. Over to you, Dr. Shreya, to take it over and start the proceedings of this first journal club of 2026.
Yes, sir. Thank you, sir. Uh, should I share my screen
Yeah,
now?
yeah. You want me? I also can share, or you can also share.
Okay, sir. So if you're sharing, then it's fine.
Okay, I'll do it. 1 second.
Okay, a very warm welcome to all of you present here. Isha ma'am, Sujata ma'am, Tushar sir, and Simi ma'am, all the residents. Vikas sir is yet to join. Thank you for joining for this journal club. So we'll start with the article discussion first. I'll introduce the very vibrant Dr. Samarth Kakar. He has done his MBBS from Jawaharlal Nehru Medical College in Karnataka. He is currently doing his MS in Ophthal from Arvind Eye Hospital in Madurai. He has been a vibrant innovator and has a runners-up trophy at Arvind Inspiring Innovator Award in 2025, and he is actively inclined towards research in clinical and surgical ophthalmology. Uh, so his mentor is Dr. Isha Chaudhary, who is my mentor here at Dr. Shroff's Charity Eye Hospital. Ma'am has been actively participating in all the academic and professional activities going on in YOSI and All India Ophthalmic Society. She has done her MBBS from Lady Harding Medical College. So your screen is not there.
1 second. Sorry. I'll just share it again.
I can share it if you want.
Yeah, yeah. You take over, Dr.
Yes.
Shreya.
So ma'am has done her MS from UCMS University of Delhi. She has a great clinical experience with more than 3,500 SICS and about 1,000 phaco surgeries. She has also performed 400 plus SICS at Botswana Cataract Camp. She is ICO certified. She has a second prize in poster and oral presentation at the ISCKRS 2017. She has numerous publications and a book chapter on clinical pathological correlation in scleritis. So welcome, ma'am. Samarth, you can start sharing your screen now. We'll start with the article discussion now.
Good evening, one and all. On the onset, I would like to thank UC and TNOA for having given me this opportunity to present at the Journal Club. I am Dr. Samarth Thakkar, uh, second year postgraduate at Arvind Eye Hospital and Postgraduate Institute of Ophthalmology, Madurai. My moderator is Dr. Isha Chaudhary, who is a consultant at Department of Cornea and Refractive Surgery at Dr. Shroff's Charity Eye Hospital, New Delhi. So the article for today's discussion will be Outcomes of Advanced Visualization in Corneal Surgery Evaluation Trial, which is a non-inferiority randomized control trial to evaluate the use of intraoperative OCT during Descemet's membrane endothelial keratoplasty. The agenda for my presentation will be the following. Firstly, will be the introduction, followed by the aim, methods and materials, results, discussion, and then I'll be clinically appraising the article using the Mary protocol. Firstly, the introduction. So, Descemet's membrane endothelial keratoplasty, or DMEK, is considered as the standard in endothelial keratoplasty. However, it is plagued with a high complication rate, with about 20% of the cases requiring bubbling and 5% of the cases going in for primary graft failure. And current literature consists majorly of observational studies or studies in which there is lack of a control group. During DMEC, intraoperative OCT has been known to help in evaluating graft-host apposition, faster graft positioning with fewer manipulations, and in verifying graft orientation. This led to conceptualization of an intraoperative OCT optimized DMEC surgery protocol, wherein intraoperative OCT would be used during graft unfolding instead of traditional overpressurization of the globe. Subsequently, a pilot study was performed, which was a randomized control trial consisting of 38 patients who were randomized into two groups. Group 1, wherein overpressurization was for greater than 12 minutes was done, and Group 2, wherein overpressurization of less than equal to 2 minutes was done. Thereafter, graft apposition was assessed in both groups using intraoperative OCT. The results of this pilot study were that there was a significant reduction in the surgery time in Group 2. Intraoperative OCT was helpful in making surgical decisions, especially in providing information regarding graft orientation. Furthermore, there was no significant difference between the incidence of adverse effects between the two groups. Even though the prevalence of primary graft failure was higher in Group 2 than Group 1, which can be considered clinically significant. However, the study was not a rigorous comparison and lacked the necessary power to compare or assert. Firstly, the adverse effects between the two groups in relation to prolonged overpressure and intraoperative OCT use, and whether or not prolonged overpressurization seems to affect the risk of graft detachment and failure following DMEC. This ultimately led to the ADVICE trial, that is, Advanced Visualization in Cornea and Corneal Surgery Evaluation. AIM was to evaluate if intraoperative OCT optimized surgical protocol without prolonged overpressure is non-inferior to the standard surgical protocol during Descemet's membrane endothelial keratoplasty. Materials and methods. The study design, as far as the study design is concerned, it was a multicentric randomized control trial, and it was performed at 3 centers: the University Medical Center at Utrecht, Netherlands, University Hospital at Leuven, Belgium, and Maastricht University in Maastricht, Netherlands. The study period was from December 2018 till April 2021. As far as the inclusion and the exclusion criteria are concerned, pseudophakic adults with irreversible corneal dysfunction due to Fuchs endothelial corneal dystrophy and who were considered medically fit for DMEC surgery were taken into the study. As far as the exclusion criteria is concerned, it excluded HLA matched keratoplasties, ocular comorbidities other than ocular surface diseases such as open angle glaucoma and ARMT. Coming to the blinding, so this was a single blinded study wherein only the patients were blinded. Coming to the study measurements, the preoperative evaluation included the following: the corrected distance visual acuity, which was measured using the ETDRS, that is the early treatment diabetic retinopathy letter chart at a distance of 4 meters. Slit lamp examination, fundus examination, intraocular pressure measurement, Scheimpflug based corneal tomography, anterior segment OCT, a posterior segment OCT to quantify RNFL thickness, and endothelial cell count using light microscopy. Similar ophthalmic examination was performed at 3 months and 6 months post-operatively. Surgical procedure. All donor grafts were organ cultured and provided pre-stripped. Grafts with a minimum endothelial cell density of 2,300 cells per millimeter square with a size of 8.5 mm were used. All surgeries were performed by experienced corneal surgeons using a standardized procedure and protocol. Preoperatively, about 27 patients underwent ND-arc laser iridotomy, and about 38 patients underwent a surgical iridectomy during surgery. A 2.8 millimeter corneal incision was made, followed by a 9 mm descementorhexis under air, which was done for 51 cases, and using viscosurgical devices for 14 cases. The graft was stained with trypan blue dye and was inserted into the anterior chamber using a glass injector. Thereafter, a no-touch technique was used to unfold and position the graft. For the control arm of the study, whose strength was 33 and intraoposity was not used, and a full overpressure was performed for 8 minutes using air. For the intervention arm of the study, whose strength was 32, the intraoposity was used as at the surgeon's discretion during unfolding to ensure complete adherence of the graft. And uh, the duration of overpressurization was either reduced or overpressurization was not done at all. At the end of the surgery, air was replaced by SF6 in both arms, with the size of the bubble being the same as the size of the graft. Thereafter, a validation intraoperative OCT scan was performed for all of the cases, and any irregularities were treated as per the discretion of the surgeon. Patients were asked to remain supine post-operatively for 24 hours. So, this is a flowchart depicting the progress of the study and the sample size. On the onset, about 139 cases taken up, were assessed for eligibility, out of which 74 were excluded and 67 were included. Depending upon the sample size, uh, 65 cases were taken up, out of which 33 were allocated to the control arm and 33 were allocated uh, to the intervention intraoperative OCT arm. However, it was interesting to note that uh, only 32 of the cases received the allocated intervention, and two cases were crossed over from the control arm to the intraoperative OCT treatment arm so as to salvage the graft during the surgery. As far as loss to follow-up was concerned, in the control arm, 4 patients were lost to follow-up, 2 being lost to retransplantation, and the other 2 being lost to reduced care of delivery during the COVID-19 pandemic. In the intervention intraoperative OCT arm, 1 patient was lost to retransplantation, whereas 2 were lost due to reduced care of delivery during the COVID-19 pandemic. Ultimately, 33 cases were analyzed under the control arm and 32 cases were analyzed under the intervention arm. Surgical evaluation. Post-operatively, the surgeons were asked whether intraoperative OCT helped in making critical decisions, and if so, how. All surgical videos were recorded and analyzed by 2 graders to record graft unfolding grade based on graft manipulation and the time taken to unfold and position the graft, as well as the overall surgical time. Outcomes. The primary outcome was to assess the incidence of post-operative adverse effects, which included graft detachments requiring surgical correction, primary graft failure, and iatrogenic acute glaucoma. The secondary outcome uh, included the number of cases wherein surgeons reported that intraoperative OCT aided surgical decision making, surgical time, post-operative endothelial cell loss, and the corrected distance visual acuity at the follow-ups. Coming to the sample size, the power of the study was taken to be 80% with an alpha value of 0.05. Taking into account attrition to follow-up, the final final sample size of the study was calculated to be 65 subjects. However, the power calculation did not take into account COVID-19 related loss to follow-ups. Statistical analysis. The data was analyzed using R statistical software version 4.0.3, CRAN Vienna, Austria. All continuous variables were expressed as mean plus minus standard deviations. Categorical variables were expressed as numbers and percentages. And comparisons were performed between the conventional treatment group and the intraoperative optimized treatment group. Independent sample t-tests were used to compare continuous variables between groups. Fisher's exact test was used for categorical variables. Relative differences in terms of percentages and 95% confidence intervals were calculated for surgical time parameters. Adjusted p-values were reported where appropriate to account for multiple comparisons. And finally, a p-value of 0.05 was considered as statistically significant. Coming on to the results, four serious adverse effects were recorded during the study period, which included primary graft failure in 3 subjects, all of whom underwent retransplantation, and death of 1 subject due to multi-organ failure right before randomization. Altogether, 7 subjects were lost to follow-up, out of which 3 dropped out following retransplantation, whereas 4 were lost to reduction in care delivery due to COVID-19. Incidence of post-operative adverse effects and the clinical outcomes. Firstly, this study showed that there was no significant difference between the control and the intraoperative OCT groups in terms of incidence of adverse effects. As has been demonstrated in this table, 26 post-operative adverse effects were noted in 22 subjects, out of which 13 adverse effects were seen in the control group amongst 10 subjects, and in the intervention group, 13 adverse effects were noted in 12 subjects. You can clearly see that the p-value of 0.644 is statistically not significant. However, it is interesting to note that the incidence of rebubbling was significantly higher in intraoperative OCT optimized treatment, whereas the incidence of iatrogenic acute glaucoma was significantly higher in the conventional treatment arm. Furthermore, there was no significant difference between the control and the intraoperative OCT treatment group regarding secondary clinical outcomes at 3 and 6 months postoperatively. This table clearly shows that with the CDVA, pachymetry, endothelial cell density, density loss, RNFL thickness, and IOP, showing no statistically significant difference. Surgical decision making and surgical duration. Of the 35 cases in which intraoperative OCT was used, surgeons reported that it helped in decision making in 14 cases, accounting for about 40% of the cases. This included 33 cases of the intervention arm, along with the 2 crossover cases where intraoperative OCT was used to salvage the graft. Furthermore, obligatory verification scans in the control group revealed peripheral detachment of the graft in 1 case, which was subsequently repositioned using 4 minutes of overpressurization. As discussed before, all the surgical videos were analyzed by 2 independent graders to grade the difficulty in graft unfolding. And here is the grading which was used. Grade 1 was when the graft lamella was primarily oriented correctly in the anterior chamber with straight and direct unfolding and centering. Grade 2, wherein graft unfolding was slightly complicated, requiring indirect folding and centering with a duration of less than 5 minutes. Grade 3, wherein the graft unfolding was difficult, requiring indirect unfolding and centering with a duration of longer than 5 minutes, requiring air injection with a continuous balance or solution exchange. Grade 4, wherein the graft unfolding was extremely difficult, requiring direct manipulation of the graft lamella for unfolding and centering by using cannula and forceps. So as can be seen in this table, the p-value of 0.011 in the shows that intraoperative OCT significantly improved the surgical decision making when the surgeons were inquired from. The mean skin-to-skin time and the graft unfolding time was about 13% and 27% shorter respectively in the intervention arm. As can be seen here, the surgical skin-to-skin time showed a relative difference of 13%. The overall overpressurization time showed a relative difference of 71.9%, and the unfolding time showing a relative difference of about 27%. Coming on to the discussion, the intraoperative OCT optimized surgical protocol without overpressurization was found to be non-inferior to the conventional protocol of 8 minutes of overpressurization with no intraoperative OCT. Hence, these results do not support the idea that overpressurization supports graft adherence. The causes of graft detachment are multifactorial and the risk ranges from characteristics of the donor graft all the way up to intraoperative and postoperative considerations. While the prevalence of adverse effects did not differ significantly in both arms, the nature of adverse effects showed a distinctive but obvious contrast, with lesser incidence of postoperative iatrogenic glaucoma in eyes without overpressure. Interestingly, while the incidence of graft detachment in both arms was comparable, rebubbling was performed more often in the intraoperative OCT arm, as has been seen in the previous table. The opinions and evidence on the use of overpressurization in DMEC as a protective factor for graft detachment from this study remains equivocal. Intraoperative OCT helped uh, in surgical decision making in 40% of the cases, with imaging being particularly useful during graft unfolding and in assessing graft orientation. And all these findings were consistent with the pilot study as well as the landmark Pioneer and Discover trials. As seen before, the surgical skin-to-skin time was 13% shorter and graft unfolding and positioning time was 27% faster in the intraoperative OCT group. The shorter skin-to-skin time was an expected outcome as overpressurization was omitted or was performed for a reduced duration. However, the efficiency and time gained by using an intraoperative OCT may be offset by the time taken to analyze the actual intraoperative OCT images. Coming on to comparison with similar articles, the first was the pilot study for the Discover trial performed by Brian Cost et al., wherein 8 eyes of 7 patients were analyzed. In all of the surgeries, intraoperative OCT proved to be of great help. There were 2 cases in which intraoperative OCT helped in identifying areas of incomplete apposition, accounting for 25%. There were 2 cases which developed partial graft dislocation at first weekly post-op follow-up, which was later corrected using rebubbling, again accounting for 25% of the cases. Coming on to the actual Discover trial performed by Patel et al., wherein 100 eyes of 76 patients were analyzed, and yet again in all of the surgeries, intraoperative OCT proved to be of great help. 2 cases developed primary graft failure, but this was attributed to poor graft quality and surgeon error respectively, accounting for 2% of the cases. 9 cases developed graft maladherence, which were later corrected using rebubbling, accounting for 9% of the cases. Coming on to another study performed by Saad et al., titled Intraoperative OCT Assisted DMEC, 14 consecutive cases, wherein 14 eyes of 14 patients were analyzed. In all of the cases, intraoperative OCT was used to check graft orientation. In 3 cases, accounting for 16.6% of the cases, it was difficult to assess the graft orientation, wherein intraoperative OCT proved to be very useful. 1 case developed peripheral graft detachment, which was later corrected using rebubbling, accounting for 7.1%. The mean graft unfolding time was 6.1 plus minus 3 minutes while using intraoperative OCT, which was significantly faster when compared to similar previous cases. Coming on to the next landmark study, which was the Pioneer study performed by Ehlers et al., wherein 531 eyes were analyzed, out of which 135 eyes underwent DSEC and 9 eyes underwent DALC. Point to note that none of the patients in this study underwent a DMEC procedure. In 9 cases of DSEC where surgeon believed full apposition was achieved, intraoperative OCT revealed persisting fluid, accounting for 29% of the cases. 65 cases of DSEC revealed persisting fluid on intraoperative OCT requiring corrections, accounting for 48% of the cases. In 5 cases of DALC, intraoperative OCT revealed suboptimal initial definition requiring further manipulation, accounting for 59% of the cases of DALC. Coming on to the positives of the study design as a comparative, outcome-based study is methodologically stronger for drawing clinical conclusions, and it attempts at providing a more holistic post-operative assessment, taking into account CDVA, that is the corrected distance visual acuity, endothelial cell density loss, intraocular pressure, and the RNFL thickness. The negatives of the study were that it did not take into account a stratified analysis of the surgeon experience. There is no discussion of cost effectiveness and accessibility of intraoperative OCT. And there is a lack of a strong, significant supporting superiority signal. Power calculation did not take into account COVID-19 related loss to follow-up, wherein 4 patients were lost because of this. No statistical matching of donor age was done between the two groups. And groups have not also been matched for the use of oculoviscosurgical devices during descemeter access. Finally, coming on to the clinical appraisal of the article using the MARI protocol. Firstly, the method. So the study design was a prospective randomized controlled trial where the objectives were clearly defined. This was a multicentric hospital-based study with a sample size of 65, with the control arm consisting of 33 cases and intervention arm consisting of 32 cases. All the patients were followed up until 6 months, and the study had a well-defined inclusion and exclusion criteria. Assignment. Randomization was well performed, and all cases were allocated into a control and intervention arm. Only the patients were blinded, and a standard pre-operative and post-operative evaluation was performed for all patients. Assessment. Primary and secondary outcome measures were well defined, and so were the adverse effects. Objective outcomes included visual acuity, endothelial cell density, intraocular pressure, and RNFL thickness. Surgical efficiency parameters like skin to skin and graft unfolding time were well recorded. Results. Both the groups showed comparable adverse effects rates. There was no significant difference in the secondary clinical outcomes, but the studies showed significant reduction in the overpressurization time and in the overall surgical time. Coming on to the interpretation, the use of intraoperative OCT in DMEC aided the surgeon in making more calculated and appropriate surgical decisions, thereby allowing for a reduced reliance on overpressurization and maintenance of graft adherence and safety. The omission of globe overpressurization whilst using an intraoperative OCT was considered non-superior in terms of post-operative outcomes. The lack of significant difference hence can be attributed to either adequacy of the conventional technique or a limited power of the study in identifying small effect sizes, or both of them. Extrapolation. Intraoperative OCT is definitely useful in complex cases and in tertiary eye care centers as well as training centers. Cost and availability limit the universal adoption of intraoperative OCT. Furthermore, intraoperative OCT is not essential in routine cases, and hence it can be used as a selective adjunct rather than a universal requirement. Thank you.
Thank you, Samarth. Very well presented. Can you stop sharing your screen?
Yes, I've stopped sharing it.
A very innovative presentation, and specifically how you have also included the other trials like Discover and Pioneer. So I would like to welcome Dr. Vikas Mittal, sir, who has joined in between now. Welcome, sir, to our journal club for today.
Thank you so much.
Yes, sir. I'll share my screen.
Good evening, Vikas sir. Glad to have you with
Good
us.
evening, Ranjan. Yes, thank you so much. I was enjoying this article, specifically the Mary format protocol. I was remembering that book that I had read long time back, studying a study, testing a test, and Samarth had, included all those things. Amazing, beautiful.
Thank you, sir.
Thank you, sir.
Have you stopped sharing your screen, Samarth?
Dr. Shreya, I think the CV is visible. We can just go full screen and proceed.
Okay. Is it visible?
Yes, Dr. Shreya.
Okay. Yeah. So Dr. Vikas sir needs no introduction at all. He is the General Secretary in the Cornea Society of India and has more than 20 years of experience and has been a teacher for us all, a mentor for us all. He is mentor for the Cornea Fellowship Program at LJI Institute since 2017 and currently founder and medical director at LJI Institute, Ambala, Haryana. So has more than 50 publications in index journals, and he has more than 250 national and international talks and courses. Thank you, sir, for joining. So will be
Thanks, Shreya. Thanks so much.
Yes, sir. So we can go on with your speech, the topic now,
Okay.
if you want to share your screen.
Sure. Yes, I'll share.
So sir will be speaking.
You might need
Yes,
to stop sharing. That's what it says.
Yes, sir, I have stopped.
Okay, yep.
So sir will be speaking on simple tests and powerful clues in corneal evaluation.
How do I? Can you see my slides?
Yes, sir, it's visible.
Visible, no? Okay, full screen, right?
Yes, sir.
Okay, fine. Thank you so much, Shreya, once again. And I think Niranjan had given some fancy name to the talk. Basically, all of you, again, welcome. And I'm really glad to see that on a Tuesday evening, you all are here. And it's a beautiful initiative. I think the whole group is doing beautiful journal clubs and, inviting people and sharing all these experiences and, learning, mutual learning. So thank you so much once again, Shreya and Ranjan, everybody over there for inviting me. So whatever the, name was given, so what I'm going to do is I'm going to talk about these 7 different corneal procedures, which are common procedures that, we do in OPD day in and day out. And I'll just tell you that why do we do it and how do we do it. So, so what I'll do is, since I can see 20 plus participants here. So I would request all of you to, participate, maybe, sending some thumbs ups, some, maybe if there are any question in the chat box. So we can, keep interacting as well. So after every this video or one procedure, I'm going to ask you that if everything is fine and then you would understand it. So give me some thumbs up so that I get encouraged, and then we'll go to the second one. Is that fine with everyone? Can I see some
Yes,
thumbs
sir.
up or
Yes,
something?
sir.
Absolutely, sir.
Absolutely.
No, I want to see that if people are alive or not. Okay. Sure. Okay, fine. So let's move on. So when we see, something like this, when we see this infections, and how do we deal with it? How we treat it? Is it that we do give antibacterial? Is it that we give antifungal, anti-xanthemeba, what it is? So we know that whenever we have to deal with these kind of patients, the first thing we'll have to have is the infection in hand, the etiology, the diagnosis. If you have a diagnosis at hand, then the overall treatment, follow-up, everything becomes, very, very, very simple. Then for that, I think the corneal scraping is the most common investigation, which is very important. And if you are a resident fellow, I'm sure if you just watch this video carefully and just pay attention to what I'm saying, you will be able to diagnose your infective keratitis well. Because the basic purpose of taking good scrapings is that scraping should have the organism. You should be able to take, where do you take the scraping from, how do you smear it, how do you then take the cultures. All those things are very important. These are very, very key things that we have to take care of when we take corneal scrapings. And how do you basically obtain that specimen? So the basic idea is to ensure that you get that organism. So you'll have to take the scraping from an area so such that the probability of having that organism is very high. So this is what we use at our institute. Two slides, grams and QH, and then we use blood agar and separate agar. That's it. There are other things also that you can take, but if you just do these two for stain and smear and two for cultures, more than sufficient, and more than 98% of the organism you can pick up. There are other medium also, but those are primarily for research purposes and not very practical. Right? So we are going to focus on four things: grams, KOH, blood agar, separate agar. That's it. This is how we take scrapings. We use 50 number blade, and same blade we can make a handle also, or you can use a Bart Parker handle to use the 50 number blade. So see, this is the infection, right? You can see there are some infiltrates. You can see some collagenolisis here. Where do you take the scraping from? This is very important. Sometimes you take scraping, send, and they'll say no organism, and they'll say you blame it on the micro department. तो ऐसे ही बोलता है. So but we'll have to see that whether we have taken the scraping from the correct place. So in this particular infection case, we are going to take the scraping somewhere from here. The edges where it is thick, there is edema, there's cellular reaction. Why? Because this is an area where the organism are actively multiplying, right? So if we take the sample or this particular area, then probability that you'll get a organism will be very high, right? So we are going to take scraping from this particular area. So this particular specimen is what we actually desire. If we take the, say for example, scraping from here, you might not get. This is just a necrotic debris. This is a collagenolisis. But this is an area where probability of having an organism will be very high. So this is how we take the, just scratch the surface. And there are two slides, as you can see. One will be used for KOH and one will be used for grams. So when we, take it for grams, we simply smear it. We just rub it on the surface and just smear it. And immediately after that, ensure that underside is marked, and documentation is extremely important. What is the name of the patient, what is the medical record number. This is very important, and you will do it right out then and there so that this slide doesn't get mixed up. So there's a gram stain. We have marked it underside also and documented the patient credentials as well. Then the second part for taking a KOH. When we take the KOH, we don't smear it, right? We simply tap it on the surface. It's not that we are going to smear. We just simply tap it. It's just that transferring that over here, not making a smear out of it. Again, underside is make a circle. Name of the patient. This is KOH. Medical record number. This is very, very, very important. And then you place it in the same tray. So grams is done. QH is done. What is next? Next would be blood agar and separate agar, right? So again, same area. It's very important to take the scraping from the same area. And here, this is what we are doing using this blood agar. In blood agar, we'll make C, these kind of C marks. This is very important because then whenever there'll be growth, you will see only in these curves. If you have the colonies along these arcs, then only it will be significant. And the colonies which are not in these arcs, that will be insignificant. If you simply tap it all over, it will be very difficult to understand what is contaminant and what is the actual growth that you are looking for. The last specimen that we take is for separate Texas agar. This separate Texas agar is generally a slant in this test tube, and all you have to do is bury your 50 number blade into the substance of that blood several Texas agar, and that's it. All the samples has been taken, blood agar has been done, separate is done. Now you take these things into the micro department. So as a general ophthalmologist, as an ophthalmologist, we all must know how we see grams QH. We should at least know how do you keep these blood agars? Where do you keep the separate agar? How do you see these colonies? It's not that you'll have to depend on microbiology. When I had come into Ambala, started my practice, there was no microbiologist around. And there was only, so I was thinking that what I'll do, how will I, deal with these infection patients? So I went to a pathologist. I said that, can you do it for me? So she said that, yes, I can do, but how do you do it? Because they were used to taking sputum, blood, CSF. They were not used to corneal scraping because it's a very small sample. Then I took the slides and showed her, see, this is how these kind of things looks like. This is how, she didn't even know that what is, why do you want a separate access agar? So there also, we need to know it. So that's why we should know that what exactly we do. So this is an incubator, which is used, which is generally at 37 degrees. And this incubator is used to keep our blood agar. So blood agar will always be in the incubator, right? And we keep seeing every day, we see how the growth, and then we document it. And this is Sebrus Dexis agar, or SDA. SDA will be kept on the room temperature. So this is not be warmed in the incubator, right? So now you know how we have either the microperson or how you have to supposed to keep blood agar and Sebrus agar. Now you mount. How do you see this KOH mount? All you have to do is just place the 10% KOH, one drop, onto that slide and cover it, close it with a cover slip, and then you see it in the normal by microscope. The magnification that you use is 40x. First in the 10x, you see where is the sample, and then in 40x, you can see. See, once you have seen how these fungus looks like in microscope, you can never forget. Picking up this fungus in QH is very, very, very easy. All you have to do is just see it once, and that's all. And we all should know it. If you want to manage infection, the QH is bare minimum that we should know. At our institute, all the fellows are very well trained, and they can pick up all these organisms very, very easily. And as I said, diagnosing fungus is not a big deal at all. So QH is done. Now comes the gram staining. Gram staining is done with the routine, the way we do it. And then important thing is, when we see it, we use oil on the slide. You have to keep it where your sample is, and then see it under 100x, and not 40x, not 10x, 100x. The bacteria is very small, so you need to magnify it so well. So 100x, you just touch that oil, and you can, this is how these bacteria will look like. This is gram positive cocci, this is gram fungus, this gram positive cocci on the blood agar, and you can see this is gram negative bacilli. It's not taken up the stain, and that's what I was telling you about. So these arcs, so you have to see the colonies along these arcs. These will be significant. If you have a colony here, that will be contaminant, right? So this is how. It's not that we have to rely on others. You should be able to see it yourself also. So these are the acanthamoeba cysts that you can see both on blood agar, on grams, as well as on KOH, right? So this was about corneal scrapings. And if you know that, what is your organism? If it's a fungus, you are going to treat with antifungus. If it's bacterial, you'll treat with antifungus. If acanthamoeba, treat with anti-acanthamoeba. It's not that, and very, very rarely you have a mixed kind of thing, then only you'll use, your mixed therapeutic agent. So this is a very important test, and you should be able to, do good scrapings. You should be so good that, suppose if you are a resident or fellow, your consultant should be so confident that, okay, इसी को देना है हमने corneal scraping करना है. If he or she does, definitely, we'll get the organism, it's there. So to summarize, you need 50 number blade, edge of the infiltrate should be taken, documentation is extremely important, KOH on 40x with cover slip, grams, you don't put a cover slip, only oil, and you watch it under 100x. Blood agar is kept in the incubator 37 degrees, and SD on the room temperature. You can take a screenshot of this if you want, so that this summarizes that what are the key things that you take care of while you are taking corneal scrapings. Hope this is clear. So now we'll go to the next video or next procedure, that is debridement. So where do you use this debridement? Your debridement is generally done in case of fungal keratitis only. And what is the aim of doing this debridement? The aim of doing this debridement is debulk that organism. Sometimes you have these plaques sitting over the cornea, and you have to remove those plaques. These kind of plaques, you can see this plaque. All you have to do is simply, use 50 number blade, or sometimes you have to use a crescent knife and remove this plaque. One part is this, and second thing is the epithelial debridement. You have to keep on doing epithelial debridement every 3 or 4 days, so that natamycin, primarily natamycin and amphotericin B, that can go into the stroma, because this has a very poor penetration. The antifungal agent like natamycin and amphotericin B, they don't have a very good penetration with intact epithelium, and that's why you have to remove this epithelium every on every follow-up. So every third day, 4 day, you can see. And how much epithelium you should remove? At least 3 to 4 mm beyond this infiltrate, you can see, so that the natamycin can go inside, saturate the stroma, and kill that organism sitting over there. Generally, voriconazole is you don't need debridement in case of voriconazole, but natamycin is extremely important. Otherwise, it will not work. You can see this patient. This patient had this bad plaque. So this patient was on natamycin for 2 months. The patient was not responding at all. Then patient came to us. All we did is just remove this plaque and started doing epithelial debridement every 48, 72 hours. And you can see within 3 weeks he improved. And we didn't change the medication at all. The patient used to tell us, doctor sahab, aapne kya kiya hai aisa? The medication is same, and how come the same medication was not working for 2 months and started working in 2 to 3 weeks? That's because the colony, this is dementatious fungus, and you have to, this is a chunk of colony, you have to manually debride it, and then only the drug will act. Okay, so this is another patient who had a plaque where this debridement was done and responded well. Very, 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 very important. The debridement, the epithelial debridement, is done for fungal keratitis and not for bacterial. The antibacterial agents are already good in penetrating the intact epithelium. So this debridement, removal of epithelium, saturating the stroma with antifungal, this is only in case of fungal keratitis and not bacterial. In bacterial, rather, it will be contraindicated to remove that epithelium, because that epithelium is acting as a protection, right? So those kind of in bacterial, there is no debridement. It's only in the fungal keratitis that you do debridement. That means the removal of epithelium. So corneal scraping is done. How you diagnose, and debridement this is a procedure while you are managing your fungal keratitis. Related to this only, the next procedure is TAVCL, or cyanoacrylate glue application. I'm sure that all of you have heard about it, and all of you must know how to place a cyanoacrylate glue. It doesn't matter that you are a Cornea fellow or not, you are a resident or not. You must know how to do it. This is a very easily available. It's not that it's very cheap, very easily available, and it can save the eye, many eyes, if you learn how to do this. So this is how it is available. There is this ampule, and then there is a syringe. All you have to do is break this ampule and aspirate this cyanoacrylate glue in this syringe, right? So this is, and your glue is ready. So we have aspirated it, and then place 1 drop of this cyanoacrylate glue on this. This is a pouch of Merosol sponge inside of it, so that it is in a sterile area, and just 1 drop, very small drop. The idea is to place a very thin layer of glue in the area where you have a corneal perforation, right? So this is a patient. You can see there's a corneal perforation in the center, and this is where we want to place a cyanoacrylate glue so that this perforation gets closed. And if you want, you can do a serial test also. All you have to do is put your blue or yellow filter, and then just touch this fluorescent strip onto the area where there is a suspected perforation, and you could see that aqueous coming out. So what are the key thing before you do a TA? Very, very important 2 things. One, it has to be, area should be de-epithelialized, and second, it should be dry. If you place your cyanoacrylate glue on intact epithelium, it will fall off. And if it is wet, again, it will fall off. So it's important to ensure that the glue stays in place. It has to be de-epithelialized. So what I'm doing here is around 2 mm area, I'm de-epithelializing. So removing the epithelium surrounding that in the perforation. Hope this is clear. You can see this whole area is de-epithelialized now. So then only it will stay, otherwise it will not stay. And then drying. So what I'm doing is Merosol sponge, drying it, and on the back side of the Merosol sponge, I'll just touch that glue that I had kept in that Merosol sponge pouch, and I'll take very thin layer and then place it here. With the back of the metal sponge, you just touch it, and within seconds it gets polymerized. It's polymerized, right? And you can see that the perforation is sealed. There is no aqueous coming out, and then you place the bandage contact lens over it so that patient doesn't feel irritation. The same patient before TABCL and after TABCL. Another patient whom you can see there's a perforation in here, and this is secondary to infection. Again, deepithelization and then drying. Deepithelization and drying. And only after it is dry, then metal sponge just touch that glue, and it polymerizes very, very, very quickly, and then you place the bandage contact lens over it. So sometimes what happens is, if you are seeing in OPD and this patient had a corneal fistula, so you are trying to dry it using metal sponge, but the aqueous keeps coming. You can see that the aqueous is coming. You are not able to dry it well. These are the cases where we should do the TABCL in OT or OR, where you will inject air bubble in the AC so that the perforation gets plugged from inside with air, and then you place the cyanoacrylate glue over it. So this was the patient. The plan was, you can see there was a fistula which was continuously leaking. So we thought that maybe we'll do a TABCL under air. You can see, so the plan was to do, so I've filled it with air, and then next step would be deepithelization. So deepithelization of the area. So this is the perforation area. So I thought that maybe we'll deepithelize it, maybe 1 to 2 mm surrounding it. You can see the deepithelization was done, and then this, because there was a continuous fistula, so air could not actually plug it from inside. So that's why there was continuous outflow of aqueous, as you can see here. So we are not able to make it completely dry. Even tried to put more air, because it was a fistula, as I said, the even air was coming out. You can see that even the air was coming out. And those kind of patients, you can use your drape, the simple that drape. Just place a small piece of drape over it. You can see here, and then just use. So this will ensure that the aqueous stops temporarily, and then quickly place a cyanoacrylate glue over it, and it's polymerized as well. Many times, because you can see this is a quite kind of file. So you get a pseudocornea, and then vessels comes, and then it heals well. Sometimes it is this kind of patch with TABCL is used as a temporary measure. By the time you do a penetrating keratoplasty or anything like that. So TABCL is clear. Many times people ask me that for how long you should keep this cyanoacrylate glue on. Majority of the patient, you have to keep it for sometimes 2 months, 3 months, 4 months. And when do you remove it? So it is important. So what happens is, the moment you put a glue, the epithelium will come under it. When it heals, the epithelium will come under it. Once it is completely epithelialized, it will fall off. As I said, it cannot stay over the intact epithelium. If you want to see that whether it is healed and you want to take it off, all you have to do is just touch it with merosol sponge. Don't try to pull it. If you use force to remove that TA, many times what happens is you remove it, and then you see that the perforation have occurs once again, and then again you'll have to take the patient in OR, plug it with the air, and then do a TABCL again. So what you have to do is just touch it with a merosol sponge and see if it is loose. You can see if it is loose. If it is loose, it will come off very easily. So we don't have to force. We will not use a 50 number blade here. Just a merosol sponge, just touch it and see if it is falling off. If it is epithelialized under surface, so the undersurface is completely epithelialized, and that's why this glue will come off very easily. So as I said, it attracts and also it attracts a lot of vessels. It has its antibacterial properties also. So once it is healed, then this TABCL will come off easily, or glue will come off easily. So to summarize, what are the key points? Before applying cyanoacrylate glue, it should be dry, deepithelized surface, use a very thin layer. Don't use don't make a hump like that. And BCL is generally used to reduce the irritation of TA. It's not that bandage contact lens is stuck over there. Bandage contact lens just so that the otherwise patient will feel a lot of irritation, foreign body sensation. And very, very, very important, this needs to be underlined. We have to treat the primary etiology. Whenever we are doing a TABCL, it's simply a procedure to seal that particular perforation. But why that perforation has actually happened? Is it a sterile perforation due to some, rheumatoid arthritis, SGS, those kind of things, or it is secondary infection? So we have to take care of the primary etiology. Otherwise, you'll have a melt once again, right? So I hope this TABCL part is also done. So we have last 4 videos, I think, remaining. So next is on anterior stromal punctures. See, anterior stromal puncture is basically used to, make the patient symptom free. The patients where the epithelium is loose due to bullous keratopathy or anything, epithelium is not able to stuck well, and this patient will keep having irritation, watering, sometimes severe pain. And also, suppose you have a RC, recurrent corneal erosion, because of some or the other reason, and epithelium is not able to hold at all. Those are the cases where you may consider ASP or anterior stromal punctures. So the important, what basically why we do it and how it actually helps. It creates puncture and it creates that inflammation or injury, which will ultimately heal with scar. So when there will be scar, it will anchor the epithelium. So that is the aim, is to make multiple small scars which can anchor the epithelium, so that epithelium will not be loose and the patient will not get this redness, watering, irritation. That is the basic aim of doing this stromal punctures, right? So what we do is just divide this cornea into 4 half, and then in individual quadrant make lots of these punctures. The idea is the puncture should be very close to each other, so that you don't have, you can't even see a space in between. It should be maybe less than 1 mm space. So you make sometimes you have to use 100 punches, 150, like that. So what we'll do is you just divide it into 2 half, this quadrant, and then each individual quadrant you will fill in with these punctures. And what we are doing here is we are using the 26 number needle, bend it like the cystitome, and you have penetrating it. And what we are doing is, the idea is to reach mid to posterior stroma. It's not only anterior stroma, because if it's only anterior stroma, many times this epithelium is so thick, you hardly goes inside. So you have to reach half of the cornea, and these corneas are already edematous. In case the epithelium is very loose, you can also get rid of epithelium and then make the punctures directly on the stroma. But if the epithelium is there, it's okay. With the epithelium on, you make these punctures. You need to be patient and very slowly, and make multiple, maybe 100 in each quadrant. Many times these patient, 50% at least of them, they would need another, sometimes second or third sitting also. Sometimes you see some areas where in between these punctures where your scar is not formed. So this we will use in patient where don't have much of visual potential, or if there is a visual potential, you stay away from the pupillary area, because otherwise there'll be scar in the pupillary area, and we don't want that. Sometimes these patients who have a bullous keratopathy, and you are not planning any endothelial keratoplasty, these are the patients we use anterior stromal punctures in as a symptomatic measure, so that the patient doesn't feel pain. Right, and then you place a bandage contact lens, which will stay there for 6 to 8 weeks. And this is one of the patients where anterior stromal puncture was done, and you can see that scar was made. So important thing is visual potential you'll have to see. If you are planning an endothelial keratoplasty, so we'll not do ASP because otherwise you'll have those scarring. And in case somehow you have to do it, then you'll ensure that you spare the pupillary area. And as I said, it is not anterior, it is mid to posterior stromal punctures. Only anterior will not help. Okay, so first 3 procedures were related to infections, scrapings, debridement, TABCL, and this is related to altogether different etiology, where we are doing it for symptomatic purpose. So we have just saw a video of glue, which is called cyanoacrylate glue. Now there is another glue that we use in ophthalmology that is called fibrin glue. So let's see what is fibrin glue and where we use it. In cyanoacrylate glue, we were using it to plug a perforation. In fibrin glue, it's a glue, a biological glue, where it will be used to stick something with something. We'll see what is that something with something, right? Because why I said that, because it is used, it has a multiple usage. So it's as I said, it's a biological tissue adhesive, which is actually there. It's a coagulation cascade. All we have done is we have tried to use we have artificially created it, and then we are using this fibrin glue, which comes from human only. So this is a tessel that we use. We have used others also, but those don't work well. So, but this is very, very good, and it has basically two components. One is called thrombin and fibrinogen. It is already there. There are two wires. How to do it, how to prepare it, all those things are written in it. It is not a big deal at all. Your OT assistant or anybody can prepare these two different components of fibrin glue. And the idea is to mix these two components on table so that you get that fibrin glue made. And this is the incubator kind of thing. And these are, as I said, two generally a small vial, a bigger vial, two black and two blue. It's everything is written over it. The basic idea is we are preparing fibrinogen and thrombin. And on the table, we are going to put a drop of both so that makes that glue, which will be used to stick something with another thing. These are the small steps. As I said, that it is already written. It's not a big deal. Your OT assistant can prepare. So let's see the example. So here, the fibrin glue is used to stick amniotic membrane to the underlying deepithelialized cornea surface, right? So this is where we are using a fibrin glue. So what we have done here is, used whatever amniotic membrane we want to, size of amniotic membrane that we want to use, and then we are going to use. So this is the first component. This is the second component. One is thicker, that is fibrinogen. Then other is thinner, that is thrombin. We have to be quick here, because if we take some time, it will become a blob kind of thing, and then it becomes very difficult to stick it. It needs to be thin, evenly performed, evenly spread, and you have to be very quick. The moment you place these two drops of prothrombin, fibrinogen and thrombin, quickly you place your amniotic membrane. In this particular case, we are using the fibrin glue to stick the mucous membrane graft in case of a SGS patient. So the one part of mucous membrane is sutured on the lid edge, and the posterior part we are using fibrin glue to stick it. So here, the one mucous membrane is used to stick on the other surface. So in this patient had undergone OSSN, ocular surface neoplasia, that was removed. So just to ensure that the surfaces remains good, we are again using fibrin glue to stick amniotic membrane under surface. We also use fibrin glue to stick CAG in case of pterygium. The principle remains same. Two components, one drop and then another drop, thicker and then thinner, and be quick and place these amniotic membrane back. We use it for slit also. You can see there's a thicker part, and then there's a thinner one, and then you place that amniotic membrane back very quickly, spread it, and then you cut it, make whatever size you want, and then wait for a couple of minutes, and then surgery is over. So you should know that how do we make fibrin glue, how do we use it. What is the catch point is here is you have to be quick. Okay, so the second last video. So this is supratarsal steroid injection. This again is used, and every ophthalmologist should know how to do it and what all things to be taken care of. This is generally used when you want to inject a depot preparation of steroids to remain for some time in the supratarsal area, right? This is and the indication is very severe VKC like shield ulcer, lots of giant papillae, or limbal VKC, this kind of giant papillae, or these kind of bad limbal VKC. Otherwise, the limbus can be harmed, right? So very severe VKC. This is the patients where we use supratarsal steroid injection. Very important is rule out steroid response beforehand. How do you rule that out? See, these patients are generally on steroids. So see those folders. If you see there is a spike of IOP, don't use, because otherwise it is a depot preparation which is going to be there, and it is not very easy to remove that depot preparation if it remains there. So also maybe you can give some prednisolone for some time, see 2-3 weeks. If there is no, you just need to ensure that the patient is not a steroid responder to the best of your knowledge, right? So how do you do it? Doing this particular procedure is not difficult at all. You can lift the upper tarsal area, and this is the area. This is the tarsal plate. So superior to that tarsal plate, there is a small gap, so there's a potential space in which you can go with your 26 gauge needle. So go at the upper other side of lateral side of your tarsal plate, and then you come out while you are injecting. You can see this. You are coming out while you are injecting. This is how it is done. So it is very important not to come in this area. So your injection should be behind this or superior to that tarsal plate. If your injection is within this tarsal plate, you'll feel a lot of resistance. And if you feel seeing a lot of resistance, that means you are not in the right space. But if you are not seeing resistance, as you can see here, let's have a look at once again, going on the other side while you are injecting, and withdrawing your needle like that, and you can see that space. And if you see this, you can see this small swelling. This means that has gone in the right space. So you should know how to give a supratarsal steroid injection. Of course, the treatment will remain the cause of the why you are giving this injection, that is VKC, and you'll have to take care of that part, right? So okay, so all we have to ensure is that the patient is not a steroid responder. Last video. So this lady had undergone phacoemulsification, smooth surgery, non-dissolving edema. This lady was referred to us for endothelial keratoplasty. This is how the patient was. We did something and patient improved to 6'9" within 5 days. What we had done was desmetopexy. So many times, as cataract surgeon, many times you see, oh, surgery is very smooth, everything, and next day you see corneal edema, where you are not expecting it. When you are not expecting corneal edema and you see corneal edema, the first thing you should suspect is descemet membrane detachment, and specifically if you have this kind of localized kind of edema, right? You can do OCT and see where your descemet membrane is. So how do you do desmetopexy? Again, this surgery also, this procedure is something that every cataract surgeon should know how to do it, how to diagnose it. You can see that descemet membrane over there. You can see it with a slit lamp only, and generally it is seen in the area of dense edema. You can see here, so and then you can substantiate it or confirm it with the OCT if you want it. The catch point here is you should have a better view. So what we are doing here is removing epithelium so that the view is better. You can actually delineate where the edema is, where this descemet detachment is. So this is the descemet membrane area, as you can see here, and we will enter with a MVR from where you have a clearer cornea. So it is very important to enter from an area which is a clear cornea, and then use your cannula with air inside and touch the either IOL or iris. You have to ensure that you are behind the DM. You must ensure that you are not in the interface, because if you are interface and inject the bubble there, then the whole DM will, the descemet membrane will rather increase. So you go from an area where the cornea is clear, and the tip of your cannula should touch, anything, IOL down there, and then only you inject your air bubble. Very slow air bubble, and then and immediately after air bubble, generally this DM settles. Very rarely you have a very bad detachment where you have to really scroll or do all those kind of things. The majority of patients, they do very well. All you have to do this. You don't need a SF6, C3F8. Just now we have saw a beautiful article where pressure is not that important. Important is descemet membrane should remain intact. Just see within 2 hours. What I'm doing here is tap so that we'll removing some part of air bubble, and you can see the cornea has got clear within 2 hours. So that is so magical it is. But your final air bubble should be the one which is movable, and you keep some air bubble in that inside, and give the patient supine position for some time. And next day, if you is the same day after 2 hours post-op, you can see the whole DM is attached and the cornea is clear. So this also is magical kind of thing, and we all should know how do you do desmetopexy. So these are, you can take a screenshot if you want. We don't need SF6, we don't need C3F8. Simple air is enough. We need 80% air fill, and you have to ensure that before patient leaves your clinic, you do some tap. At least 50% of air should go out. Otherwise, the patient will have pupillary block glaucoma, and patient will call you in the middle of the night and tell patient to have a supine position, and then these patients, this again is a very easy to perform procedure. So that's all. So we have we talked about corneal scrapings, debridement, EBCL, infection, and for symptomatic purpose, anti-somer punctures. We have discussed how we use fibrin glue and where all things, supratarsal steroid injection, and last we touched upon desmethoxy. So hope, it was of use and you could understand something. Thank you so much once again, Shreya and Ranjan, everybody over there.
Thank you, sir, for
Hi,
such
Isha.
an enlightening presentation.
Sir, hi.
Good to see you. Yes, Shreya, please carry on.
Thank you, sir, for such an enlightening presentation. I'm sure our residents here, Shravant, Shanwati, Ashwati, Raghav, and Manisha, have learned a lot. So moving on to the discussion for the article, I would like to invite Isha Chaudhary ma'am for her comments on the article. Please, ma'am.
Thank you, Shreya. So I think before I start, I'd like to say that the presentation sir presented was very informative, very simplified. So it's good for everyone. I mean, I just didn't come to know how the time passed. And it was, even though I perform these things routinely, but there's always something new sir tells. And we all know sir is a great teacher. So I think it was a very great talk.
Thank
And
you so
thank
much.
you for sharing it and making it so interesting. And secondly, I'd like to say that Samarth has worked really hard on the presentation, and he's also simplified this very difficult article. So I think, I mean, I've gone through this article a few times now. So I would say that definitely that I think maybe in complex cases, there's definitely a role of intra-op OCT. And if we read this article, they've found uh, good results because the time duration has decreased significantly. But the comparison, I would say, is not very fair because in their conventional group, they have not marked the graft. So their study is based on the fact, and they're basically comparing over pressurization in the two groups, that where you're not. So in one group, they are doing a conventional surgery where they have used overpressurization to ensure adherence. And in the other group, they have made sure that the graft is adhered completely with the help of OCT and not used overpressurization. It is fair to say that we probably sometimes go a little overboard with the overpressurization in terms of duration, just to be very sure that all the effort that we've put in and the precious tissue we've put in doesn't get detached. But if we look at the study results, even though not significant, the detachment and the rebubbling rates are higher in the OCT group. So yes, definitely that I mean, if a person is marking the graft, and if that graft's orientation is confirmed with the mark at the end of the surgery, then the effect of overpressurization should be exactly the same. So I would say that that's the biggest flaw in the study, because they are not able to confirm the orientation of the graft because they have not used any additional method to decide that the orientation in the end is correct. However, they have just seen that, yeah, of course, with the intra-op OCT, the orientation can be checked. And if you're stuck, like how they've used two crossover cases, so in those cases, definitely it is helpful. And maybe in cases where your visibility is poor, those are the cases that you can take up additionally in with the help of OCT, because those you may not want to operate on without an OCT because you can't see the orientation. So in that case, yes, definitely it helps. But I would say that to see how much overpressurization is ideal, one would need to compare the conventional graft with a mark and one without a mark but using intra-op OCT. So I think that is my take home from the study. Others are free to comment.
I'm sharing my screen. I would like to introduce our panelists for today. Yes. So, welcome Dr. Tushar Grover, sir. Sir is a senior cornea, cataract and refractive surgeon and
Your
has
screen
a...
is not visible. Your screen is not visible.
One second, ma'am. Is it visible?
Yes.
Welcome, sir. Sir is a senior cornea, cataract, and refractive surgeon with a strong international training, academic work, and leadership roles. He is currently the medical director at Vision Eye Center and a visiting consultant at Sir Gangaram Hospital. Sir is trained at Arvind Eye Hospital, Madurai for his post-graduation and has done his fellowship from Narayana Nethralaya and has more than 150 invited talks, live surgeries, courses at multiple national and international, and has multiple national and international awards. So also publications and mail section editor for refractive surgery DOS Times and is coordinator for ISCKRS Delhi. Welcome, sir.
Thank you so much, Dr.
Yes, sir. So our next panelist is Dr. Anu Malik, ma'am. She is assistant professor and cornea cataract and refractive surgeon at Dr. RP Center for Ophthalmic Sciences, AIMS. Ma'am has done her MBBS and MS and was a gold medalist as well from LLRM Medical Care. She has been an active academician and has UG and PG teaching experiences and is thesis. She is the managing director at DOS Times, section editor in DJO, and recipient of several national medals and involved in state level blindness control and diabetic retinopathy programs. Welcome, ma'am. Going on to the statistical critic for today, Dr. Simi Chaudhary, ma'am. Ma'am is my senior from University College of Medical Sciences, New Delhi. Ma'am has completed her long-term fellowship in cornea and anterior segment from LV Prasad, Hyderabad, and MS in Opthal from GNEC Maulana Azad. She has core surgical surgical expertise in cataract, cornea, refractive, ocular surface, and contact lenses, and is in charge at Bosch and Lomb Contact Lens Clinic in LV Prasad. She had the Best Free Paper Award at TraumaCon 2022, was invited as a speaker at ESCRS, APAO, AIOC, Keracon. She has multiple peer-reviewed publications in cornea, IJO, BMG, and BMJ. She is a member of a lot of societies and IACLE as well. Welcome, ma'am.
Thank you, Shreya.
I would like to invite comments from all our panelists. Dr. Tushar, sir, for his positive reviews on the article, please.
Sure. So, I mean, of course, very nice presentation, and Dr. Isha has pointed out some of the limitations as well. So I'll talk about the strengths that there are strengths in the study as well. So I think one of the things is that the trial design is appropriate. It's a prospective, multi-center, randomized trial. So that is the right way to go. This is even the methodology of being a non-inferiority methodology is correct because you want to demonstrate that it is equivalent in terms of safety. You're not trying to demonstrate superiority. And the endpoints that they've taken is also meaningful clinically because they're looking at the adverse events. So those are all appropriate. The fact that it's multi-center, I think there's one study site from Belgium as well. So that again makes generalization a little more acceptable. The techniques that they've defined, the technique of DMEC is standardized. So that again is a good thing. And otherwise, even the way they've reported their crossovers, their deviations between the two groups is has been done quite transparently. So I think that's a good thing. Apart from that, even their interpretation as such is reasonably balanced. They've not overclaimed the benefits of what they're doing. So I mean, yeah, I mean, there definitely are limitations. I would love to point that out too, but I'll leave that to Dr. Anu. But there are benefits, and it does come out from this that there is some utility of the intraop OCT as well. It did aid in decision making, and I think 40% of individuals, there was a reduction in, of course, the overall surgical time, because you're not over pressurizing, so the time is there is going to be less, but also there was a reduction in the graft unfolding time. So, and again, it's a study that is relevant to modern DMEC practices. So I think these are the positives for me, and we'll leave the limitations to Dr. Anu.
Thank you so much. So, the key limitation, according to me, is the absence of superiority in the expert hands does not equal the lack of value of IOCT for DMEC. So, the trial answers a narrow question like routine DMEC by experts, but it does not negate the potential benefit in training or complex cases or future of IOCT technology. See, endothelial cell loss was assessed but not powered to detect the subtle differences. And given that IOCT could theoretically reduce the mechanical trauma and the over manipulation, long term ECD outcomes may be more revealing than the clinical endpoints that have been discussed. Or we can say the sample size was insufficient, like events like primary graft failure or upside down grafts, interface fluid related failure, they are relatively uncommon. So the sample size could have been increased. Moreover, a non-inferiority design assumes a priorly like IOCT is not expected to be superior, but merely not worse. So patient-reported outcomes or quality of vision-related metrics could also be included, like visual quality, contrast sensitivity, or visual recovery speed, and the patient satisfaction also. So the most important unanswered question that remains is from a time-based safety measure like overpressurization to an information-based decision making. We have to align this with the principle of IOCT technology. So,
Also the blinding that they have done in this is only a single blinding, and the surgeons and the researchers are not blind. Only the participants are blinded. So,
yeah, it
your
could also
opinion
have
on
been
that?
stratified. Stratification could have been done according to the corneal clarity also. We could have included trainees also, and long-term graft survival outcomes should also be commented on. There was also mentioned that the power calculation did not account for COVID-related loss and cost-effective analysis.
Yes. Yes, ma'am.
Yeah. Yeah, and something I would have liked to know is my incidence of rebubbling going to reduce, which it doesn't really give you an answer at. And just looking at just composite adverse events doesn't give you much information, because the mechanism in which all of those adverse events occur is different. I mean, you would rebubbling is different from somebody developing glaucoma, or not glaucoma, like a rise in intraocular pressure, or somebody having graft failure. So it doesn't give you answers. I would completely agree with that.
So IOCT optimizes the intraoperative decisions, but it cannot control
Yes.
the postoperative biology. So rebubbling depends on other intraoperative
Yes,
additions.
there are other factors in play as well. Absolutely.
So, as a statistical critique, I am supposed to critically analyze this paper. And I actually agree with Dr. Tushar. Yes, there are some good points. And the authors have been very clear about what are the things that they have not included in the paper. But there are more limitations compared to the strengths in the paper. First of all, as Shreya very clearly noted, very correctly pointed, that the study was single blinded. So the surgeons were very clearly knew about the allocation. Obviously, it could not be blinded, but that does leave a potential space for a bias at that position. Then, although a good point, although there was a predefined outcome measures at follow-up visits, but again, the surgeons were not but the surgeons were, can you just give me a minute, please? Yes, sorry for that. And secondly, although they had put up a predefined outcome measures, but again, the surgeons were not blinded. There also there is a potential for a assessment or evaluation bias. Then coming to the confidence interval. So there was an adjusted risk difference. Good thing they had taken the adjustment of all the factors, different surgeons, different centers, different surgeons' experience, different in patient's condition, agreed. Although the diagnosis was same. But the confidence interval was very wide. It ranged from -10 to +9, including 0. So that wide confidence interval does tell us that the sample size was small, the variability was more, even the events that we're talking about are rare. So that does predict the limitations in the study itself. Then the next point about the role of prolonged overpressure. Again, this study was aimed to compare intraoperative OCT protocol with the standard surgical protocol. So they could have had a third arm where they wanted to compare the outcomes of prolonged overpressure. This was not necessary to be included in the same arm. As Dr. Anu very correctly pointed out, that it does not, the OCT actually does not play any role in the detachment or the bubbling or rebubbling rate. So that was something which could have been easily kept independent from the other factors. Then coming about talking about the sample size, it was small, it was modest. So a total adverse events is basically a blanket number. We actually would want to dig deeper and want to know the individual adverse events, particularly the rebubbling rates, if we are trying to compare the prolonged overpressure. And the most important, according to me, which was the non-inferiority margin, which the authors have kept 10%. So now, if we talk about the non-inferiority margin of 10%, and we compare that with the upper limit of the confidence interval, which was 9.84%. So that 10% margin is bang on at the 9.84. So any decrease in the margin, the non-inferiority margin, would have led to a different conclusion. So if say I wanted to debate that we could have kept it 5% or 7.5% or even 9% for that matter, then in that case, the data is same, the result is same, but the conclusion would have been that the study or the new protocol is not non-inferior to the standard surgical protocol. So yes, there are a lot of limitations in the paper, but overall, agreeing with what Dr. Isha said in the beginning, it is something which can definitely help in complex cases where the visibility or the visualization intraoperatively is very limited. And if you also see the supplement table, which Samarth has shown in his presentation, that grade 4 difficulty unfolding was maximum in the intraoperative OCT group. And there also majority patients surgeons had easy were benefited with the intraoperative OCT in the grade 4 type of difficulty in unfolding instead of grade 1, 2, 3. So that does tell us that yes, intraoperative OCT does give an additional benefit when the surgeon cannot see in dense corneas or difficult cases. But the cost benefit analysis needs to be kept in mind before we actually jump to the use of intraoperative OCT compared to the standard protocol. I think that was a lot of limitations. I should have kept few.
No, that's perfect. And I think, like you said, a non-inferiority margin of 10% by itself is quite generous, right?
Yes,
I
yes.
mean, it's
They have
quite.
been very liberal with that margin. They could have just reduced it and the result would have been completely different. Yeah.
But how do you decide on that margin in such studies?
No, so there are many factors that are to be taken into account. So if there would have been somebody from the authors group in this JC, I'm sure they would have defended saying that the rebubbling rate is high, it's 20%, then the sample size and the events. So there are reasons, but then there is a debate of, just reducing it by 1% and the conclusion would have been different.
I think the reason why they did not use a lesser inferiority margin was because that will lead to significant increase in the sample size. So probably that could be a reason why they did not go in for that. But yeah, definitely. And there's, I think, another problem that was that they have not matched the donor age. They have not matched a lot of things pre-operatively. So no matching has happened between the two groups. So even though if you look at the table, it looks, I mean, they have specifically mentioned that matching has not been performed. I am not very good with statistics, but if the groups are not matched, especially when it in terms of donor age and in terms of use of visco OVD, then probably to say confidently that one group the time was less as compared to the other, it's not fair. I mean, so that is also another point. But however, like everybody is discussing, it's who would not want an intraopacity in their OR, so that, I mean, everybody will love that confirmation. I mean, it's sometimes it's quite a struggle to do a DMEC. So I think it is definitely a good thing, but at what cost? So yeah, if you have it, it's great. But if you don't, I think it's okay.
Then no regrets, yes.
Yeah.
Mhm. Yeah, the cost is not a factor that is discussed in the study
Yeah.
as well. And this is not funded by ZEISS, but there is a mention that the institute does have research grants from ZEISS as well. And one of the authors is a consultant for ZEISS. But it's good, it's nice of them that is mentioned,
Yes.
but no direct financial involvement with the study, I guess. Great. So any queries from the residents, I guess?
Yeah, so are the residents here? Shravan, Ashwati, Raghav, can you please switch on your videos?
Yes, ma'am.
So do you have any questions from the article? Anybody?
Ma'am, a question that I had was like, what is the learning curve when it comes to the intraoperative OCT? And what about the like duration of the surgery? How does it affect that?
So does anyone want to answer that?
I mean, I have not used an intraopacity. I have just seen it being used. So from whatever I've seen, I don't think there's much learning curve to it. But if there's somebody who's used it real time, probably is a better judge of that. But I think there's not much learning curve to it. You just watch it like a normal OCT. I think you switch it on and you watch it. And if your orientation is not correct, also, I think it helps a lot when you're doing an endo-in kind of a DMEC. There, because you need to fold your graft and take it in and then open it in a different orientation. So I think there it has a special utility as compared to your conventional DMECs, which is endo out. I don't
Rightly,
think there is a learning curve to it.
rightly said, Isha. The initial familiarization is short, and you become comfortable with the basic image interpretation and the system operation after a few cases only, like 10, 20 cases only. Depending upon the procedure, you get to use it and integrate smoothly with the surgical decision making also.
Okay, ma'am. Thank you.
In my opinion, just to answer your question, if you have learned DMEC, trust me, you will not have any trouble learning intraoperative OCT.
Shravant, any questions from your side?
Ma'am, I had a query regarding one of the points in the article, ma'am. They mentioned that they had more chances of rebubbling after intraopacity based DMEC. So why is that happened, ma'am? Because usually it should have a better outcome, right? Is there any way that there's a reason for that?
No. So just one input from my side. One statement that you need to correct. They were not supposed to show that there is better outcome. They don't want to show that it is superior. What they're trying to show is that it is not it is not inferior. That's why. So yes, you are correct. You very correctly pointed this also, that the rebubbling rate was higher. And anybody would think, because the entire thing was same, the surgical time was lesser, the unfolding was faster, the overall surgery was better, then why was the rebubbling rate higher? Anybody would think that probably because the overpressure time was lesser in this arm compared to the second one, That could be a reason, and I still think that is the reason. But they have also mentioned in the paper that when they compared the rebubbling rate with the overpressure time, it was actually not significant. But again, because the sample size is small, we need more studies with larger sample size to back this answer.
Thank you, ma'am.
So the
Also,
study, sorry, go ahead.
yes, sir, please go
Sorry,
ahead.
no. So the study itself mentions that they're not powered to analyze it. Yes, it is. They understand that that's going to be a question that everybody is going to have because they've talked about overpressurizing versus not overpressurizing in the IOCT group. But we can all assume that it could potentially be because of that, but we cannot really conclude that from the study.
Yes, sir.
I think another addition, one, obviously, this is correct, saying that we don't know how much overpressurization is ideal. Because in their pilot study, they have used 12 minutes as that cutoff, whereas in this study, they've used 8 minutes and less than equal to 2 minutes. So maybe a study is required, maybe with intraopacity, where you can compare different time periods of overpressurization to see whether detachment or the rebubbling rates are minimum. Also, like I mentioned, that they haven't clearly mentioned where the OVD, where the decimeter excess was done under OVD. So, if all of those cases fall in the group of IOCT, then there is a possibility that that could be a potential reason why detachments and rebubblings are higher in that group. So, that particular point has not been mentioned in the study.
That's a valid point.
And also, that was one of my thought that we do a combined surgery mostly, wherein in the article they have taken pseudophakics with Fuchs endothelial dystrophy as the study group. So, what is your comment on that? So they have taken old age patients with pseudophakia with Fuchs endothelial dystrophy, but I have like since the time I have joined my fellowship here, I have seen more combined surgeries like cataract with a DMF like that.
I think that's fair to just look at pseudophakics here because you don't want too many variables being added here. So it is true
Okay.
that you will end up doing combined surgeries, but when you're studying it, you don't want to have some cases where you did combined, some cases where you did it on pseudophakics. So you want less variables involved. I think that's fair, I think, to me.
Okay, sir. So any further questions from the residents? I think we can wrap up our article discussion. I would like to invite Prasanna sir for his final comments.
Thank you, Shreya. A huge shout out to you.
Thank you, sir.
To all the faculty members out here, the whole journal club skeleton was planned by Dr. Shreya, who's a newly joined member of our JC team. So thank you, Shreya. We in the YOSI Journal Club, we have a formality certificate distribution at the end. So we'll just complete the formality and also thank each one of you. So we are doing this for the last 5 years, and today we had a collaboration with the TNOA Journal, and we also had the president of TNOA for the first 1 hour or so, and I think it's a collective team effort. Thanks to each one of you. So to the viewers watching this out here, we always have a presenter, monthly mentor, and recently we started having the keynote speaker and wonderful discussion by the panelist, Dr. Tushar, Dr. Anu, and we also have a statistical critic by Dr. Simi today. And recently, last 3, 4 episodes, we have brought in the residents corner to make sure the residents ask very simple and basic doubts to all the stalwarts. So with that, I would like to start the certificate distribution. Thank you, Vikas sir. Sir wanted to leave a bit early, so we had to sandwich him between. Apologies for the flow getting disrupted there, but we had to do it. Thank you, Vikas sir, for the wonderful and enlightening talks, and it was very, very insightful. And thank you, Samarth. You started and you kickstarted the day for us. It was very nice of you to take the tough job of being the presenter. Of course, again, monthly mentor, Dr. Isha Chaudhary. Thank you, Dr. Isha, for taking up the mentorship role. And of course, again, two of my good friends and buddies, Dr. Tushar. Thank you, Tushar, for being here. We had to run a 1.5 hour webinar. Thank you for
Thank you
taking
so
time.
much, Prasanna. I really enjoyed it. And thank you, Shreya and Samarth. Really good work.
Thank you.
Really
Thank you.
enjoyed it.
Thank you, Tushar.
Thank you, sir.
Thank you again, another good friend, Dr. Anu, for taking your time, patiently being throughout the webinar and helping out with the YOSI and all the young ophthalmologists out there. Thank you, Dr. Anu.
Thank you so much.
Thank you. And of course, our statistical critique of the day, which always adds more bite to the paper because we always feel statistics is something that we ophthalmologists sometimes tend to not really fully understand. So critically dissecting a paper, Dr. Simi Chaudhary, thank you for taking time and helping out with the most toughest part. Thank you for being here.
Thank you for inviting me for your JC. This is the first time that I am being a part of UC JC, and I really enjoyed it.
Thank you. Thank you, Dr. Simi. And of course, the vibrant five, Dr. Shravant, Dr. Raghav Gupta, Dr. Manisha, Dr. Ashwati Deepak, and Dr. Shanmati. I think you guys added a lot of inclusivity because we really feel we are doing it for the YOs and we really wanted you guys to throw simple questions, basic questions, whatever doubts you have. You can still in the chat box or in the group. We'll not be dissolving it. We'll be adding it to a community of UC Journal Club and you can just keep continuing whatever doubts you have. And of course, again, this webinar is a huge shout out to Dr. Shreya. So Shreya has recently joined this 5-year-old team. So we are all getting old and we are all soon going to move on the other side. So we are grooming Dr. Shreya and Dr. Ritu. And this whole webinar, 90 to 95%, it was Shreya who really conceptualized and brought life into this with a lot of new energy. Thank you, Shreya.
Thank you so much, sir. Thank you.
Thank you. Thank you, Shreya. And also our team, I would like to acknowledge some of the back-end work. Ayushi, who's also one of the core team members. Dr. Anujit. Anujit is one of the founding members of the YOSI Journal Club in 2021, and he's still handholding people and he's trying to make sure that the transition is very smooth. Thank you, Anujit.
Thank you, sir.
Thank you, Anujit. Of course, Naranjan Karthik, again, Dr. Naranjan was one of the members instrumental in getting the academic partner Microlabs vision. And now it's also an industry partner collab one. And Dr. Ritu, again, a new member. Write to us or get in touch with any one of us integral core members. We would definitely like to have you on the other side. And it's an all-inclusive JC. You can also be part of the faculty team and looking forward to more such collaborations. If we have anybody from the micro team, we would like to thank you as well. And if you guys want to have a quick word, we would like to have your word, team Micro Labs Vision team. Naranjan, is anybody there from micro?
I am not able to see them, sir. I don't think we've been joined.
We would also like to thank team Numerotech for all the backend support. And with that, we will quickly have a photograph with all of us. Manjula ma'am, can we go off live? I think she's not.
Yes, doctor. One second.
Okay, yeah. So big thanks to everybody and handing it back to Shreya for the closing comment. Shreya, all to you before the photograph.
Thank you so much, sir. It was a great experience for me as well. So, roping in all the stalwarts and their comments on the article now during the discussion and organizing, I had a wholesome experience. Yeah. Also from the team, Anujit sir, Ritu ma'am, Ayushi ma'am, and Niranjan sir, and you have been guiding me so well in coordinating this. Thank you so much.
We'll end with a group picture, YOSI style, with the YO symbol. We're requesting all to... Anujit, you are taking the picture?
Yeah, sir. I'll take the picture. So everyone just do this.